Good morning, everybody. It's a great opportunity for Chief Plante and myself to be able to address a large portion of the unit. It's rare that we have the opportunity, so we'll take advantage of this. You have received a lot of information in the last 3 months, and the goal today is to do an overview of what we went through for the last 3 months. And to talk about the way ahead. What I would like to do to start with is to start from the beginning on the Friday the 13th of March. It was a very strange day. We started the day at 7:30 in the morning with a briefing telling us to prepare a contingency plan for the entire unit because we were expecting orders from the CDS to shut down our activities. And myself and all the staff here at the headquarters, we worked pretty much all day to prepare this contingency plan. Around 2 o'clock in the afternoon, we had a meeting with the executive of Health Services Group here. And to our surprise, we were told that, oh, by the way, it will be business as usual. So we scheduled right away a meeting with all your DET commanders and clinic coordinators, and to my surprise, I had to inform them that it will be business as usual, but I felt very uneasy about that. And about 2 hours later, we received the orders from the CDS telling us to shut down our activities, basically. So the next day, we published our first task order that basically directed your DET commanders and clinic coordinators to reduce the activities to emergency care only and to keep minimum manning within your DET. And we kept that posture since then. Have we been on idle since then? Absolutely not. Folks that have been in the clinics have been extremely busy in some of your DETs with minimum manning, taking care of emergencies. Folks that you were told to stay home, you did an outstanding job because from the information I've received, most of them are safe. Most of you didn't been infected, and you follow all the directives that were given to you. We were tasked right from the start with some very important national level tasking. The first one was with up laser contact tracing, a request for assistance that was filed by Health Canada and Public Health Ontario. At the beginning, we had a team of 30 personnel and that were involved in calling patients in Ontario, making sure that they were safe at home, and doing follow-up with them after they were screened by Public Health Unit in Ontario. We were able to scale down to a team of 18, but they are still very busy contacting patients in Ontario. There's no end date yet on this task. The second task was to be involved with long-term care facilities, and right from the get-go, our unit was extremely proactive, and we deployed our member very quickly to Quebec, more specifically in Saint-Jean, and then they were dispatched to long-term care facilities in Montreal. So we had a team of 42 volunteers to start this task, and I think we're down to about 36 right now involved, and both in Quebec and Ontario. So they are doing an extremely good job. Some of them are in leadership job, which is great, and we have dental officers, Dentex hygiene, doing all kinds of good works, and your performance and your dedication has been recognized by all. We also been busy updating our one dental unit standing orders, and we had a team of 12 volunteers under the supervision of Chief Plante that were involved in rewriting our standing orders, which is not a small task. Then we have folks involved with the CDO task force. So the task force was an advisory committee for the CDO to develop his directive. So we had 4 members from one dental unit involved with that committee. On top of that, we had 10 members that were involved, or I should say even 10 teams that were involved on standby, just in case we would have MDCs deployed across Canada through Plante to provide humanitarian support and logistical support to Canadians. They did not deploy, but they were on standby. Also, we, from the example of Major Ashley Mark, right from the get-go with the Endo webinars, we had a series of about 14 or 15 webinars so far. Try to keep connected with you at home and folks at the DET and keep you engaged with very important topics, both clinical and not clinical. And one of the most important one was the one on PPE that was developed by Det Borden. And that webinar and the training videos that were produced by Det Borden will be used for training in all detachments right now. And last but not least, we have also members that were deployed in forensic mission, both Major Sylvain and Major Kizwe from DDS deployed to Toronto to identify the remains of our soldier that died in the helicopter crash in Greece. So as you can see, we were extremely busy as a unit from starting 13th of March until now. Right now, what's going on? Well, 2 weeks ago, the CDS provided us with his order, and his order was extremely clear that starting 1st of July, he would like to see the operational readiness of the Canadian Armed Forces to ramp up. And also you would like individual training, mainly basic training in Saint Jean and in the other training bases like Gagetown, Wainwright, Kingston, and Borden to resume. So that means that we have to be prepared to support the CDS intent, and that's why we are restarting our activities. The CDO published is a new directive dated 1st of June, and this is what will be implemented. The unit published our task order. That is the plan to resume our activities, and we'll talk a bit more about that. I would like to go back in time and discuss the CDO's directive and where it's coming from. Right at the beginning, we start planning our contingency plan for the unit, and one main question we had is, what should we do if we have patients that will show up and they are symptomatic or they are COVID positive? And our first reflex was to look at opportunities on the civilian sector and see if hospital will be able to provide us that service. And we find out very quickly that the civilian sector was either unprepared or didn't have the capacity to support that. So that's why we had that discussion with the Chief Dental Officer and his team and tried to develop an approach how we would treat our own internally, the ones that are symptomatic or COVID positive diagnosed. And that's where you look at different options, and it was very clear that you had to innovate and find out quickly how we can do that. That's where the health filtration unit were looked at, and because of the great work done by Major Fournier and Lieutenant-Colonel Langevin and all their team, they were able to develop a plan using closed operatory air filtration unit and adequate PPE. Right now, we have the capability in-house to treat our patients that are symptomatic or infected. So that's a great success story that we should celebrate. Now what we need to do is to treat the others, the ones that are not symptomatic, the ones that are symptoms-free and disease-free. That's why we developed the task order. So it's a phase approach, and the first phase is what your leadership at the local detachment are doing right now. So we ask them to understand the CDO's directive and to understand the task order very well, and if they have questions, to call us back. Then we ask them to contact you guys at home and make sure that we understand very well what is your personal circumstances. And then to explain to you how the return to work plan will work or be implemented. And then to prepare for phase 2, which is to ensure that we have enough PPE in our deaths and make sure you're getting all the trainings necessary to be able to do your job. Things have changed a bit since March, and our posture for PPE and how we treat our patient is a bit different. So you need to be trained about that. Also, we need to implement the CDS directive, because the CDS and the Deputy Minister have also published directive about workplace safety, and we need to implement that. So that's what the task order is doing. It's to merge what is clinical, dentally related, and what is D&D CAF related, and implement that. So once the training is completed and we ensure that you fully understand the procedure and you feel safe, then we'll start treating patients from a prioritized base. And for priority, what we use the CO's one dental unit priorities. So priority 1, 2, A's are the most important at this time. So that means we will be treating patients that suffer from emergency dental conditions and patients that treatment have been postponed since the beginning of this crisis. So these patients are our priority. The other priority is up readiness and deployment. So units across the country that have been placed in high readiness status, and units and members that are deploying are priority, and they should receive the care they deserve before they deployed. And then we go down the other priorities. So treatments that were started prior to the crisis that were not urgent, and now we need to continue on. And then other priorities like periodontitis that needs to be treated, and patients that required long-term care treatment like orthodontics, perio treatment, people that have full mouth rehab, things like that. So that's where we are going right now. What are my expectations? Well, I expect that we'll have limitation doing this, and we're not naive. We fully understand that PPE might be a huge limiting factor. And we have addressed that through different forums, different ways, and it went up to our commanders. And our commanders voiced that he acknowledged that, and he believes that internally within Health Services Group we have that capability. So we're pushing really hard under the leadership of Lieutenant-Colonel Bussière to ensure that you guys are getting the PPE required to implement the directives. We fully understand that through our civilian supply system, our supply capacity is extremely limited. So we try to go centrally and get the purchasing power of our medical colleagues Right now, we don't have a warm, fuzzy feeling. I would be very honest with you. They understand that we need PPE, but I think they underestimate the volume of PPE we're using in a dental clinic versus a medical clinic. Because one thing that I would like to remind everybody is that our PPE posture right before the COVID-19 crisis, we had an extremely high standard of PPE to start with. And we were burning a lot of PPE to start with. And now with the new directive, we'll be burning even more. So that is a limiting factor, and I expect your leaders at every detachment to keep us appraised of your local situation regarding PPE, and centrally we'll try to make sure that you're getting the PPE through a national level purchase program. But we'll have to play week by week, and we'll see how things goes. The other limiting factor will be personnel, and that's not in a negative aspect, not at all, but we have to be realistic. Some of you have kids at home, and fully understanding that from province to province, the restriction regarding daycare and schools are very different. So access to daycare can be limited. Schools might be closed. Understanding that your family plan may be off the chart because you don't have access to grandpa and grandma like you used to have, or easy access to family. So I understand that will be a limiting factor, and again, that's why I ask your local leadership to contact you, see how we can mitigate that, and understanding that in a detachment there's only a few people, mainly AS2s, that can do their work from home. All of the rest, you need to be in our clinics to be able to do your job. So that will be a limiting factor. Other people may have some MELs that may prevent them to work, and we will deal with you on a case-by-case basis and see how, again, we can mitigate that. You may have other personal circumstances, and I would suggest that you voice that to your chain of command, and again, we'll see how we can mitigate. Right now, most of our public servants at home are deemed on leave with pay through Code 699. But as we required you to come back to work, then you should be able to come back to work. Again, with the caveat that there might be some personal circumstances, and we'll deal with that. We are very empathic, and we are very aware of everybody's limitation, and we'll try to support you as much as possible. The other constraint we have to work with are the directives. Our CDO position is very, very cautious. He's very prudent in his approach, so that means that there's a lot of restrictions that are put forward, and we have to implement. There's a good thing about it, so you should feel extremely safe coming back to our clinic. The friction point will be where it may impinge or impact our ability to support the CAF mission. And I see these directives as evolving, and they have already evolved from March until now. And depending how the dental profession is going in the future about not only COVID-19, but our new posture regarding PPE in the future, it will for sure influence the CDO's directive, and expect that there will be changes in the future. What I expect from you and from your local detachment is to voice your concerns about both PPE and CDO's posture and the mission we ask you to perform. And if there's friction points between the two, please voice them, and we will collect them here, and we'll sit down with the CDO and we'll see how we can mitigate them. I will stop here right now, and I will let.
You need a break?
Yeah, I need a break, so I will let Chief Plante to address you a bit, and after that we'll go through some of the questions that you sent us, and we'll cover that, and then we can open the floor for live questions.
Okay. First and foremost, I'd like to thank everyone involved. As you can see, we have been very, very busy. But the CEO and I have been very overwhelmed with all the extra effort that we got from all the detachments. Everybody really pitched in because we were down to almost half of our unit. And everybody, worked double the time and spent evenings, weekends to make sure that everybody was, comfortable and had everything they wanted. The purpose of this webinar was basically for us to be able to alleviate some of the anxiety that surrounds the whole returning to work. When we did when I sent an email to the DETs inquiring about potential subjects for this webinar, most of them were basically worries about how do we start back. So this is basically what we want to do, is we want to alleviate some of that anxiety. So we've got a bunch of questions. Yes. And the CEO already answered a few of them with regards to leave, but keep in mind that we don't have all the answers, because right now we're evolving with the directives from the higher HQ, and so we only have so much information. So we're going to try to do like we did the last 3 months and keep you apprised. As soon as we have an answer, we will share it.
Absolutely, and please rest assured that when you bring your issues forward, we action them as soon as possible. Some of them, they need higher up decision, like CNP and CDS decision, and then we have to wait. Sometimes we were told, there is a Ken4Gen coming up for HHT. Well, for a period of 3 weeks, every day we were told, it's coming, and it took 3 weeks to come out. So it's not that we have not voiced your concerns and our concerns about, the conduct of HHT. That was passed on a long time ago. But we need for our decision makers decisions before they are implemented. So we'll go through some of your questions and we'll talk about that. Je voudrais dire aussi pour notre personnel francophone, bonjour. Et puis, la plupart de nos communications, je comprends que c'est surtout en anglais. Et puis, je m'excuse de ça. La raison principale, c'est que le niveau d'information qui est passé, puis la rapidité nécessaire pour passer l'information exige qu'on les passe en anglais rapidement. Puis comme vous avez remarqué, le volume d'informations puis la grosseur des documents est tellement élevé qu'on ne peut pas demander ici à une personne au HQ qui est déjà super busy de faire de la traduction sur le fly comme on fait d'habitude. Fait qu'on doit envoyer ça à la traduction. Fait que ça prend un petit peu plus de temps là, avant que ça se fasse traduire. Mais n'hésitez pas à poser vos questions en français là, aujourd'hui ou en temps normal, là, juste à contacter votre équipe de commandement régional, puis on va répondre à vos questions en français en tout temps. So one of the first questions I have here, is there a plan to do some testing of our personnel before they show up at the DET, and the same thing for our patient? That's the $1 million question, and for 3 months now, Health Services Group is working really hard at Force Health Protection to have access to a reliable test. Not only reliable, but it will be quick. So the best test will be something that will be like 95% reliable and will be able to give us a result in the same day, because you understand that if we test somebody today and we get the results in 2 days from now, well, if you're positive, you're positive. But if you're negative, well, I did not lock you down in the clinic for 2 days. You went back home and the patient went back home. So the test just gave you a snapshot in time of your condition 48 hours ago. So right now we don't have that test that can give us a reliable results within minutes or a few hours. So that's what everybody's working on. As soon as we have that available, that will be great. But at this time, we don't have that. And at this time, the recommendation from Force Health Protection is that if someone is symptomatic, a healthcare provider or a patient, you stay home and you follow the local procedures from the medical clinic to get tested. And if you test negative, then you follow their direction. They may say you're good to go, you come back to work, or they may say you self-isolate for 7 days, 10 days, or 14 days. But that's where we are right now. The other question is, if one day we have a vaccine, who will be vaccinated? So for military personnel, it will be through your medical clinic. For civilian personnel, you'll need to use the medical system of your province and get vaccinated. A question about hygiene, and there's a lot of questions about hygiene. So does it mean that you need to completely stop working? It's a complex question. If you look the priority of care at this time, hygiene is not a priority of care. There will be an asymmetrical implementation of priorities. Big deaths that have a lot of backlogs of priority 1 and 2 patients, cleaning is not their priority right now. Other smaller deaths that do not have a lot of backlog of emergency care and will be able to go through that quickly, they might resume hygiene care. What is important is to follow the directions about PPE, and the goal at this time is not to produce aerosols. And I can open up that parenthesis about aerosols. Keep in mind that aerosols is part of our work in dentistry. It has been part of our work for the last 100 years. Every time we put our hands in the mouth and we put air in the mouth, we generate aerosols. And that's part of our job, folks, to be exposed to bacteria, viruses, spirochetes, all kinds of microbes every day. That's our jobs. And all of us, we live an happily life until the 13th of March with no issues at all. Now we have to deal with another bug, and we'll just take the precaution and the guidelines that are published right now to deal with that new bug. And that's it, that's all. COVID is not an end or an end state. It's not an enemy. It's just another bug within our working environment. That's it, that's all. So we need to keep that in mind. Another aspect is that aerosols are not, again, the enemy. Aerosols by themselves are totally inert. It's when you add bugs to aerosols that then you start having an issue. And I would like to remind everybody that at this time, there is no scientific evidence of transmission of COVID-19 through dental aerosols. There are 0 studies out there or case report out there of transmission of COVID through dentistry. Does not exist. So that said, we don't want to be careless. We don't want to be rogue. And we take all the precaution to make sure you're safe. But keep that in mind. When we test people for COVID-19, when they do the swab, they don't go in your mouth. They go in your throat or they go in your nose, because COVID-19 stays in the airway, doesn't stay in the mouth. The mouth is just a transient way for the COVID-19 to get out of your body, but it's not where it stays. So you need to keep that in mind. Do you feel that the pandemic will permanently change some aspect of the way deaths operates in the future? Yes and no. I think the enclosed room and the air filtration unit are there to stay, and that's a great capability in the future, not only to deal with COVID-19, but all other bugs that are airborne. That will give us that capability. So that's a permanent change. For the rest, how we will keep that PPE posture after we find a vaccine against COVID-19 and it's not prevalent in our population, I don't know. I really don't know. We'll see. We used to be, for the last 30 years, a profession that was geared against blood-borne pathogen like HIV, hepatitis A, B, C. And we were extremely successful as a profession to protect ourselves, protect our families, and protect our patients. So I'm extremely optimistic about the future, that our industry will find a way to protect us for airborne pathogens, since it might be a threat for the future. Will there be change in clinic layouts planned for the future? Well, we already discussed about closed rooms. Will all rooms be closed in the future? In the long run, I have no idea. When I think about the layout of our clinics or the clinics in the civilian sector, for a while the concept has been an open concept for all kinds of reasons. I'm thinking also about hygiene schools and dental schools, and you have a very large floor plan with about 60 to 80 chairs all open. I don't know how they will plan that for the future and how they will be able to go ahead and treat patients in a COVID environment. So we'll see. Like Chief Plante said, there's more questions out there than we have answers to them, but we'll see. Your guess is as good as mine. So what happens for personnel, both military and civilian, with no health care plan? We already discussed that. The way I see it is that DND as an organization will be very understanding and very flexible, I would say up to September. And that's with the assumption that in September most provinces will resume daycare and school will start again. At that time, we'll see what will be the position of the CDS and the Deputy Minister, but that's what we will be following. And that's what we have been following since the beginning of this crisis. My expectation is that it will be pretty much status quo, so we will be very flexible and understanding that there will be an operational impact on our ability to treat our patient and make them fit for operation. And if there's an impact, I would like your local command teams to voice that, and we will push that information through the chain of command and let know the commander of Army, Navy, Air Force, and Special Ops that sorry, but this is the impact. Can an employee refuse to work due to health and safety reason in a job that requires them to work clinically with potentially infected patients? My first take on it, my personal opinion, every patient is potentially infected of anything and everything. Again, we are healthcare workers, and we deal with healthy patients and we deal with sick patients. That's part of our job. What we have to make sure is that we are well protected. And I can guarantee you that with the extremely conservative approach of the CDO, you guys and girls are extremely well protected. Does an employee has the right to refuse to work? Yes. But if someone refuses to work, that person will then have to prove why they feel that our work environment is not safe for them. So there's a process in place right now through work safety committees on base, and we have not tested that yet. These folks are folks that are usually involved with general work safety issues, not specific to healthcare settings. So if you have a case of a person that do not want to work because they don't feel safe, my first reflex will be to have a chat with that person, listen to their concern, try to respond to their concern with facts. If we cannot resolve it at the local level, then that issue should be brought up to our level. And our level, we were directed that we need to generate a critical incident report that will bring up health services group and chief military personnel for their awareness. And then we would probably engage with the Labor Relation Office, and we will have an open and very honest discussion with our personnel that do not want to work, and find out what's the issue and try to resolve that issue as soon as possible. You can deal with that in a very, bureaucratic way, or you can, in my approach, it's to try to resolve it more informally. We are all in the same family. We want to take care of our own, and we recognize that some people may have concerns, and we try to resolve it as quick as possible and as lowest level as possible. A lot of question about new graduates. I think we will have about 24 new graduates coming in our clinics, and that will be a challenge. a huge challenge, and we recognize that it's probably not the best time to have 24 new dentists to come in. When we ask for, physical distancing of 2 meters, then when we are lacking PPE, and when we try to implement new directives. But that's a fact of life. They are coming into your debts. And another fact is that we don't have enough dental assistants to support them. So later today, I'm sending a briefing note up our food chain, asking for about 24 FTE of dental assistant Canadian, and we'll see what the response will be. And I'll be quite honest with you, I feel that we will have a lot of resistance from people in charge of HR and controller at Health Services Group. They will challenge us to justify that in different ways, but we are prepared. We did our work, and we'll see what the response will be. We're using a business case approach. If we have to send a bunch of patients downtown because we're not treating them internally, it will cost a lot of money. And we are able to show that hiring 24 Canadian dental assistant is way cheaper, and at the same time we keep 24 dentists busy in our clinic. Not only there's the money aspect, but there's all kinds of intangible, like the time saving, a patient not going downtown. All the time you guys are saving because you're not busy filling paperwork, sending people downtown, dealing with the claims afterwards, and also all the entering in CFHIS, and not to mention the quality of care and patient safety issues. So this is the state where we are with new grads. Now the next question will be about mentorship. My reply back to you is do the best that you can do with mentorship. With that huge influx of new grads, I don't expect we'll be able to go through the mentorship program as planned. And but at the same time, it's a very important aspect of our job to mentor our subordinates. This is why we are a great organization. It's because we take care of our patients first and foremost, but we take care of our own. So mentorship should continue, maybe more in a informal way, I would say, rather than fill all the forms that we're asking you to fill. But it needs to carry on as much as you can. What is the plan for BDoc and courses like the QL5A at the training center in Borden? Our suggestion to the training center was to carry on with the course in-house. Looks like it will not be possible. And if we stick to that, the issue is that our folks will not be OFP, will not be at the occupational functional point quickly enough, and that will have all kinds of ramification and consequences. So to avoid that, we have no choice but to go ahead with distance learning. So the training center is working right now on a package for both BDoc and I guess for the Q
as well. So, nothing on the sergeant's course yet, but definitely the corporal is in the works.
So more to follow. We expect that there will be a package that will come out for this fall. We hope or after Christmas, but training will resume, but totally in a different way for now. Keep in mind that also folks at the training center have deployed, and for dental training, they rely pretty much like 95% on one dental unit to provide incremental staff, and we are short of staff right now with our own being deployed, not being available. So that's where we are regarding that. Physical distancing, well, it's the task order and the CDO's directive are quite explicit on that, so we need to maintain physical distancing of 2 meters. If not, then you should wear a mask in your desk. And so you may ask the question, what about lunchtime and break time? So I leave that to your det commander and clinic coordinator to sort that out. That may need that you may have to do a rotation for lunch and break to avoid to have everybody in the same room at the same time. So the goal at this time is to keep physical distancing, and at the det to manage that through wearing of mask if it's not possible, and rotations in some areas. And that will vary from one det to another. Loops, and that's a good question. Someone asked the question, I need loops to work, and you asked me to wear all kinds of PPEs, and because of that I cannot wear loops. And what about quality of care? And that's a good point of friction that I mentioned before. Quality of care versus PPE. And following directives. Directives are directives. Directives are guidelines to help you to do your job and achieve the mission. Directives are not law from God. They are not law from Parliament. So directive changes and directives need to be adapted to reality of life. If I would be a patient, I would prefer that my dentist wear his or her loops and provide me with high quality of care if the dentist feel comfortable with having the PPE required for his or her protection. If because you are wearing loops to be able to provide quality care and you feel that you don't have the PPE required to feel safe, please voice that to your det commanders and we'll deal with that situation. But bottom line for me is that you don't compromise quality of care because of a directive. At no time it should be a compromise. The same thing with our patients that are symptomatic or diagnosed. The directive said that treatment must be postponed and that you should use a pharmacology type of treatment, basically painkillers and antibiotics. That means when you do that, it's for the period of time the person is symptomatic. And right now the period of time is 14 days. So that means after the 14 days you need to see that patient. It doesn't mean that this patient goes in limbo and gets refilled of painkillers and antibiotics for weeks. That's not the goal here. The goal is to treat our patients. Yeah. Fully understanding that implementing the directive will have a huge issues on time management, and this is something that it will be a nightmare for yourself and your det commanders and clinic coordinators to book patients. because we don't know yet how much time it will take to set up rooms, how much time, supplementary times it will take to do the procedure, and how much time it will take to clean the room, remove all your PPE, and then there is the question about the waiting time between patients, which is another friction point. And again, the CO's posture is to be extremely conservative, more than any provinces out there. But this is what will apply right now, keeping in mind that directive changes. And if the waiting time between patient has a negative impact on your ability to do your mission, I need to know that. And we'll collect that, and again, we'll sit down with the CDO and discuss the impact. But fully aware that we will not be able to see the same flow of patients. And I told all your DET commanders and clinic coordinators that I have no expectation this year about the dental care program, nor that there was before COVID. There's no magic numbers out there to reach, such as 80% fitness or 90 or 95% phase 1 completed. There's never been this type of pressure on your DET commanders since I've been CO of one dental unit. So my expectation is that you do the best that you can with what you have, with the constraint you have, following the priority of care. That's what I'm asking you to do. Yeah, there's a lot of questions about N95 and masks. I would like to make the distinction between mask and respirators. It's two different things. So mask, you used to wear mask every day in our clinic, and we have different type of mask. We have surgical mask and non-surgical, and different level from 1 to 4. The difference between a 1 and a 4, it's not the ability to filtrate particles. They all filtrate particles extremely well. The difference is the protection against fluid. So, and when we talk about fluid, it's not aerosol, it's splashes. So, you know, when you rinse the patient's mouth and there's a splash of water, it goes in your face. That's what the differences of mask will protect you, some more than others. If you use type 1 or 2, you'll need to change your mask immediately because the fluid will go through the mask quicker. With type 3 or 4 mask, it will prevent the fluid to go through the mask quickly. Keep in mind that right now the procedure we ask you to provide, them with a rubber dam on. And we ask you to rinse the patient with hydrogen peroxide before you treat the patients. So patient has to be asymptomatic. You have the patient screened before they enter your room. You ask them to rinse their mouth with hydrogen peroxide. You put a rubber dam on. If you wish to clean the surface of the tooth with hydrogen peroxide, you can do that too. So now you have a clean tooth surface with a clean rubber dam, which isolate the airway because the virus is located in the airway of the patient. And now you treat the patient. So imagine you have a splash. Well, the splash, it's water from the 3-way syringe that will hit the rubber dam and hit your face. So what is the risk there of contacting COVID-19 or any other bugs? I would say it's extremely low. So that's what we ask you to do right now. If you need to do a treatment without the rubber dam, what we ask you to do is to follow the CDO's protocol, which means you use a closed room with the air filtration you need in full PPE to protect yourself. And I would see that when you have to do, let's say, extensive frost, or you do a surgical extraction that will generate aerosols. So that's for mask. N95 are respirators. That's different. The goal of a respirator is to filtrate particles. That's the main goal of an N95. N95 is an ISO certification, so you may have all kinds of N95 masks, from commercial and to surgical mask. And in between you have all kinds, some that are rigid, some that are flexible, some that have valves, some with no valves. And they all certify N95s, and they all do their job they're supposed to do, which is filtrate particles of less than 0.3 microns at a 95% efficiency level. So that's the standard they must meet. So right now, you have access to either a commercial or surgical grade N95 mask in your detachments. Some people have voiced their concerns that because it's non-medical, it's not high quality and we should not use. That has nothing to do with the efficiency or the efficacy of the mask. The difference between a surgical N95 and a non-surgical is the ability to block fluids, meaning splashes. So it's doing its job against aerosols, against particles. The difference is with fluids. And that's why when we ask you to wear N95 mask, we ask you to wear a face shield. And the face shield is the part of the PPE that will block splashes, if there's any splashes. So we use these guidelines, and these guidelines are not coming from our rear end. It's coming from Health Canada, and it's coming from Public Health Agency Canada, and it's coming from Force Health Protection for DND. So these agencies and these experts told us that we are just fine with commercial grade N95s. So that's why we have this posture right now. So I think we went through pretty much all the questions you sent us, so we'll go with the live questions.
Yes, sir. There's a question from Sergeant Killam. So there was an example of, and her question was, as the team in Iraq mentioned, so we had a webinar a few days ago from the team, Captain Zeeler. Can we be more decisive in the deaths as to what procedures can be done without a dental assistant? For example, to save on unnecessary usage of PPE. So I asked, okay, well, do you have a specific example you can think of? And here's her example. So the example at her dead, both dental officer and dental tech donned high-risk PPE for a bite plane adjustment. And the dental officer could have done this solo. As well, another patient had a toothache. They both wore all the PPE, but in the end, it was a wisdom tooth issue. Patient was given meds, and she says wasted PPE. So that brings up one example of kind of a biplane adjustment. And then also, what are some of the other things you see that the dental officer can do on their own?
Well, absolutely. In a case of an occlusal splint biplate or plate adjustment, or any device adjustment, it's not required to have the dental assistant with full PPE. And again, you need to manage the risk and use your judgment. When you have a dental apparatus, you take it out of the mouth, and that apparatus can be disinfected. So take the time to disinfect it, and if it's disinfected, there's no COVID on it. There's no bugs on it. So you don't need to have full PPE gear for that. Maybe one practice for sick parade issue is to wait before you have your diagnosis, before you have your PPE posture, to do an exam on a patient that is asymptomatic. You don't need full PPE. Your normal PPE is good to do an exam. So do your exam, do your case history with the patient, have your conversation with the patient, and when you establish your treatment plan, then you establish your level of PPE that will go with it. And I think it's to have a common sense approach. And if you have question about that, I would suggest talk to your DED commander. And if your DED commander is not sure, well, I would suggest the DED commander to pick up the phone and call the DCO and have a chat with them. It's difficult for me to go through a bunch of examples because each situation will vary depending on the procedure you'll be doing and what is the risk that your patient represent. So right now, just for your essay, there is 15 active cases amongst all Canadian soldiers in Canada. And these 15s, they are fully tracked. Like we know exactly who they are, where they are, and they should be at home self-isolated. And there's people calling them every day at home to make sure they stay at home. And if they show up to your clinic, well, there's a note in CFHIS that says that these folks are COVID positive. In total, since the beginning of March, since the beginning of the pandemic, there's been only 115 Canadian soldiers that were infected with COVID. And more than half of them were infected while they were working in long-term care facilities. So they were in an environment where they were surrounded by COVID-19. Your clinics are not filled with COVID-19. And the great majority of your patients that will show up in your clinic have not been in contact with COVID-19. There's been no death of Canadian soldiers due to COVID-19. 75% of death in Canada related to COVID-19 occur on a population of 80 years old and older. Then 25% of the remaining were between 70 and 79, or 60 I should say, and 79. So it's not the population we're treating. We're treating 18-year-olds up to 55. So these folks are not the ones that have issues in the Canadian population right now.
Sir, we have a question from Ms. Crystal Surrett, and she asks, is moonlighting frowned upon since private practice seems to be have different standards with regards to PPE? So moonlighting meaning we're working on the outside of private practice.
Yeah, right now the stand at Health Services Group is that moonlighting is not permitted. That's our stand. So we try to avoid that people are working in several clinics, and that was an issue on the medical side. That's how the severity of contagious or the effectivity, I should say, of COVID-19 in long-term care facility was so important. It was because healthcare providers were moving from one facility to another and were infected, and they were infecting several people in different facilities. So at this time, moonlighting is a no-no.
As much for them as it is for our patients.
Yes.
All right, thank you, sir. Another question here. What happens if a civilian employee becomes positive and needs to give their contact tracing names to public health? Do we provide the military names?
Yes. And that's a good question. Right now, Health Services Group is looking at patient tracing capability, and what they would like to do is to do patient tracing for both our civilian personnel, our contractors, and our military personnel. So we'll see how will be implemented, but they are very serious with that, because they understand that if we simply rely on public health units from provinces, some are, let's say, a bit more proactive than others, and we might have a good ability to do tracing, and that will be reflect on our ability to identify our own folks, and with some provinces will not be able to do that. So hopefully this will be implemented soon. So what I would ask is all our healthcare personnel, from receptionist, public servant working in the chair, Calian providers, and our military members, to be open and honest with us. And the goal here is to protect your coworkers, protect our patients, and protect our families. So one thing I want to ensure is that we want to protect privacy, and the fact that you're COVID positive, it's a medical diagnosis, so there's privacy involved. So what I would suggest is that in this particular case, for a public servant getting positive, is that the public servant should have a chat with the dental detachment commander, an honest discussion, and what the det commander will do, the det commander will liaise with the wing surgeon, and not mentioning names, and what we'll do, we'll have to do personnel tracing and find out who was in close contact with that person, and without disclosing the name of the person, every other colleagues and patient will be contacted and will be requested to get tested, and proper follow-up will be done after that. Either they test positive and they are placed in isolation, or they test negative, and then in consultation with medical authority will decide if the person comes back to work or not.
All right, thank you, sir. We've got another question from Sergeant Keith, and he states, with all the safety protocols in place, and we have the blessing of the CDO and the CO of one dental unit to see patients, what do we do with a Calian dentist that still feels unsafe to come to work?
Well, a big, and we recognize that some people may not feel safe, and that's normal. Our tolerance to risk vary from one person to another. And again, we acknowledge that. A big part of risk management is education and information. So I ask the command team to take the time to inform our personnel about what are the risks involved and all the mitigating measures we have implemented and continue to implement to reduce the risk. Keeping in mind that in no healthcare settings there will be zero risk. And I'm not even talking about COVID-19. I'm talking about any infectious disease. That's part of being in healthcare setting. If it's to the point that you cannot accept that risk, I would say that maybe you should have a serious reflection about what you want to do in life. For the specific example of a Calian provider, you should contact your regional Calian rep and contact also your original team here at One Dental Unit HQ. And on our side, we'll raise another CCRI, a critical incident report, and we will get into contact with Calian here at the national level, and we'll ask questions about what they intend to do with this provider. And I would suggest also that at the debt level, you have that conversation with your Calian provider and suggest that they contact Calian about their concern. What I plan to do this afternoon at 1 o'clock, I'm part of a teleconference with Calian National. And what we plan to do is to share with them the CDO's directive and our One Dental Unit task order. So they will have that in hand and see that we are very, very serious in our approach about safety, and that they should be able to talk to their employees and convince them that we have a safe work environment. And if they cannot or are not able to convince them, then we will ask to have another provider that is willing to work in our environment.
Thank you for the answer, sir. We got another question related to Calian and actually public servant employees very similarly. So in relation to moonlighting, what about our part-time Calian providers who are now working at their clinics? And that is there's a similar question to a public servant as well and having their own dental hygiene clinic, so it's very similar.
Yeah, that's a really good question. I don't have that answer yet,
Okay.
and that's something I need to discuss with Calian and also bring that issue up, our chain of command and how we want to deal with that. But is there a risk? Absolutely. Since, like you mentioned before, every provinces have their own stance on resumption of activity. Some are extremely liberal in their approach, like in British Columbia. Others are more stringent, like in Nova Scotia. But for us, that's a concern, and I don't have the answer yet.
All right, so we got two last questions because we're coming up on an hour. Major Mahmood has been bugging me about this question, and I'll finally ask it for you because we've been texting back and forth, and I didn't want to ask it, but he said, is it possible to reclassify an endo access with a well-sealed rubber dam as low risk, essentially using a high speed? Essentially, there should be no saliva contamination, and this seems to be a waste of an N95.
As I discussed before, there is friction points, and the management of risk is seen differently between myself, quite honestly, and the directive coming from the CDO, and I respect the posture from the CDO. He wants to be conservative in his approach, and he wants the safety of all. and I respect that. My point of view is that procedures are different. The level of risk of each procedure is different, and it should be managed differently. The issue when you do that is that you open a gray zone and you leave to the provider the decision making of how much risk the dentist is willing to take, but that may be different than the risk the dental assistant is willing to take or the risk the patient is willing to take. If we don't have a clear standard across the board, then you open the door to all kinds of issues. So right now that's where we are. But I hear you, Major Mammoth, and I fully agree with your assessment of the risk. I believe the risk is extremely low. But right now that's the posture we are, and I expect that the posture will evolve with time.
All right, sir. Just our last question, and so Trish Shepard asks, as we're in close proximity to patients, a hygienist, when providing care, and there can be, and this is both for dentists and hygiene, and where there can be pre and asymptomatic patients, can low-risk procedures, such as like less PPE be donned, so can low become high risk if the patient coughs or sneezes or has a severe gag reflex during treatment? And how would you mitigate that in your own mind?
That's a good question. What has been determined through the research done by the team working with the CDO and the provinces is that it's the procedure itself generating aerosol that will create the risk itself. The fact that the patient will be coughing, I think that should raise, if it's a non-provoked cough, I think that should raise a concern right from the start in your screening process, and maybe you would like to reschedule this patient. If the patient has a huge gag reflex, well, there's a way to mitigate that by numbing the palate of the patient, or if you want to use, if you qualify to use hypnosis, or if you want to use some type of sedation, go with that. There's ways to mitigate that. But if it's a provoked coughing, let's say the patient is choking on their own saliva or on water, I would not be too concerned about that. Like before COVID, what would be your reflex anyway? You will just roll back in your chair, move the patient forward, let them cough, and when they're done coughing, then you can resume. Again, that's in the gray zone I was talking about, and you will never receive directive, guidelines, task orders that will cover 100% of the situation that will occur, and it will be your own judgment at the chair. And if you feel that you're unsafe or you don't feel comfortable, you stop the treatment and you remove the patient. That's it, that's all. At no time I will give you the order, I'm forcing you to treat this patient. It will not occur. That said, we have a mission to accomplish. We have a job to do. We give you all the tools required to do your job. And if you don't feel comfortable, you don't feel safe, voice your concern through your chain of command, and we'll have a chat with you And if things needs to be changed, we'll change them. If you need more information, we'll provide more information to you, and we'll move on from that point.
That's all we have for questions, sir. Any last points before we sign off?
Yes?
You want to go first?
No, go first.
I was going to say, on top of what you're just saying, educate your patient, because how many times we see patients still today, like you just walk around and people just cough. They don't even cover their mouth, right? So perhaps a discussion you have before you lay down the patient. Education.
Yeah, absolutely. The chief and I would like to recognize the great job done by a bunch of people. And I hope I will not forget anybody, but I would like to say thank you for those of you who stay home, and you did your job. You did what we were asked you to do, which was to isolate yourself, stay safe, take care of yourself, and take care of your family. So thank you for doing that. Thank you for the personnel, the military personnel and civilian personnel who show up at work for the last 3 months in difficult condition, with change of directions and directive every week, asking you to implement things without having all the proper PPE all the time, asking you to manage patient in an environment where we didn't know exactly at the beginning of the pandemic where we were going to, what we had to deal with, and you were extremely flexible and understanding, and we would like to applaud you for that.
Absolutely, because there's a lot of directives and implementation protocols set in place for each different teams that came into the clinic. So that takes a lot of work.
Exactly. Thanks for the command team. You were fantastic in implementing our directive. You were there every week during our weekly telecom, and you did a great job.
And reacting to last minute requests.
Exactly. One thing you need to understand is that most of our orders were received on Friday afternoon at 5 o'clock, believe it or not, but that's how we receive our orders. So there's a lot of people here at the HQ, the regional teams, the ADG, the UPSO, our late chief of staff, that had to work during evenings and weekends to digest these orders, produce our own orders, do staff checks, prepare a lot of reports and returns to higher headquarters. They did that every evenings and weekends. So thank you very much to all the HQ staff for outstanding job since the beginning.
Because you think about it, all the reports, one detachment sends one report, 2 reports, they compile all of those reports for all 26 vets to send to a higher headquarters. So lots of work went into this, lots of hours.
Good. So finally, what I say is, be safe, feel safe. We're looking forward to all of you to come back to our deaths and see your colleagues, work with them, take care of our patients, because that's our primary goal as a unit. It's to take care of our soldiers, make sure they are healthy, make sure that they can do their job. So on that note, thanks all of you.
For attending.
Yeah, exactly.
We didn't expect such a big turnout.
And I would like again to thank Ashley for your support and allowing us to be able to reach out across the unit. So to all of you, thank you. Enjoy the rest of your day, and looking forward to see you in person soon. Take care.